Thanks, Alex.
Thanks everybody. Welcome to our May Echo Type 2 Diabetes, our second to last one for the start of 2026, because our last one we brought live on the 13th of June at the upcoming Diabetes Education Day at the Zoo in Dubbo. Tonight's topic is advances in continuous glucose monitoring, a practical update from Amanda Taylor, who you'll remember from our panel, a CDE and pharmacist at Marathon Health in Dubbo. I'd like to acknowledge the traditional custodians of country throughout Western New South Wales and their connections to land, water and community. I pay respect to elders past, present and future, and extend that respect and warm welcome to all First Nations people present today. Tonight we have on our panel Dr. Manik Maidan, endocrinologist at Orange Health Service, myself, Alex Hall, GP in Molong, Amanda Taylor, CDE pharmacist in Dubbo, Al Amor, CDE and nurse in Dubbo, and Kerry Porter, nurse practitioner in Orange and other places around Australia. As a reminder, our housekeeping, please turn on your webcams, but we ask you to remain on mute except when speaking. The session tonight is recorded. We live and work in small communities and are often able to identify the patients being discussed or the cases being discussed. If you do so, please remember to maintain confidentiality. It's important that we do so. Questions are welcomed, and I'll ask you to put your hands up using the hand up function or just put the question in the chat. And I'll endeavour to read it out if you don't feel comfortable saying it out loud yourself. And there will be an evaluation at the end tonight. It'll be a QR code which will flash up on your screen at the end of tonight's session. We'd really appreciate your feedback, particularly looking if we are going to continue these sessions into the future, what would be beneficial to you. As always, our reminder, our language matters when talking about diabetes. The words that we use to talk about diabetes affect the physical and emotional health of people living with diabetes. They also affect how people in society view people living with diabetes. So our words need to show that we care and remove bias and blame. And you might ask yourself, people with diabetes call themselves diabetic, so why shouldn't I? Evidence shows that 1 in 2 people find the label unacceptable and 1 in 4 find it harmful. People with diabetes can use whatever words they wish. Other people, and especially those of us in healthcare, have a responsibility to engage all people affected by diabetes in positive and helpful ways. And without further ado, I'll pass over to Amanda, who's going to give our didactic presentation tonight. Thanks, Amanda.
Perfect. Thanks, Alex. I'll just try to work out this technology. Sorry, won't be. There we go. I think hopefully everyone should be able to see
Yep, all good.
that. Fantastic. So I'm just doing a quick update of what's happening in the CGM space. There's lots of new updates. So I'll just sort of get started. So most of us have probably used CGM or at least aware of CGM in our practice. And certainly in the past, it's been more for type 1 diabetes, but we're seeing it more prevalently used now with type 2 as well. And not just in the specialist setting, but also in that primary care setting where most of our type 2 clients are managed. There's a number of reasons why we're using CGM. So some of the key ones, and certainly this is not inclusive, there's many reasons out there, but it really gives us that insight beyond the HbA1c and finger pricks, helps us to identify those patterns and variabilities and trends that we might miss otherwise. It helps to encourage more timely and targeted medicine adjustments. It helps us to identify and manage hypoglycemia, especially in our higher risk population groups. And more importantly for our clients, it really provides that real-time feedback for them, helping them to understand how food or activity or illness may impact their glucose. And it just helps to strengthen that self-management for them. As we're seeing CGM grow, or the use of it grow through our practices, it's really important that we've got some regulatory standardisation across Australia. And some of us might have seen recently there was a joint statement released by key peak diabetes bodies around from New Zealand and Australia, just to help drive and to ensure that CGM devices available are meeting consistent standards for the safety, accuracy, and reliability. And so that just means for us in primary care that we can really trust the data that we're seeing, confidently integrate the CGM into our routine care, and to be able to provide consistent advice to our clients regardless of the device. So in practical terms, in Australia, most recently, we've mainly used two CGMs in type 2 diabetes, main one being the Libre 2 Plus and the Dexcom 1 Plus. And they've been really good for primary care. They've supported us with allowing us to do trials or experience programs for clients, whereas typically 10 to 14 days. And these trial periods can be really powerful to help with guide that management overall. So it's really, CGM's really shifting into a practical solution in that primary care. But excitingly this year, there's actually been some growth in this space. So there's actually been 3 new CGMs come onto the market in 2026. So we've got the CareSense Air, the AccuCheck Smart Guide, and the Cyberonics GS3. At the end of the day, this isn't new technology with any of these. They all do the same thing. They're all using interstitial glucose levels to tell us what's happening with someone's glucose throughout the day, still giving us the trends and patterns. Using the regulatory statement, you'll see if you have clients use these apps, all the reporting is exactly the same. There's certain guidelines to what has to be recorded. So in terms of time in range, the AGP report is all very similar. So that's actually a good thing that they all work in the same way. From a practical point, it's really helpful. It means that we don't have to relearn how to interpret the data. It's just that we have to understand that a client might come into the practice with different CGMs. So we still need to be aware, have health professional portals set up, being able to support our clients. Because if they've gone to the effort of using a CGM to improve their diabetes health, we want to make sure we can support them and actually use the data that they're getting. All of these products, there's lots of similar aspects of them. So they're all approved for use in type 2 diabetes. They are all to be applied to the back of the arm. They all work for about 14 to 15 days, depending on the model. There's a lot of marketing in a lot of social media for this, so there is going to be a lot more patient-driven uptake for that. So I'm just going to go through each of them individually because there is some key differences between them as well. So this is the CareSense Air. It's approved only for 18 years and above. It's not approved for GDM, and it holds up to 12 hours worth of data, which is reasonable compared to some of the others out on the market. It's a 15-day wear with a 30-minute lead time. The key difference with this CGM, which you can probably see on the screen, is this button that's on the CGM. Once applied, this button actually needs to be pressed to activate it. It doesn't need to be pressed at any other time during the wear, but it's just to get that started. I should say actually all 3 of these options are only available for use with an app on their phone. So there's currently no options for those people whose phones might not be compatible. So just to keep that in mind as well. This is probably the most cost-effective CGM that is on the market. Only available online, but you have an option when you purchase them online to, if you purchase up to 6 at a time, they work out to be $45 each. So that's pretty reasonable for a 15-day wear. And the health professional portal there is known as Sense 365. Having a play with it can be set up to different clinics and users for that as well. So really suitable for those who might have multiple clinics that they go into. Then we've got the Cybionics G63. So it's a 14-day wear sensor. It's the thinnest of the sensors that are out there, of the CGMs that are out there. It actually stores up to 14 days worth of data. Um, so it could actually be really handy for those clients who might not have a suitable phone, but they might have a carer, family member who might come with them and not living with the family member, but they do see that family member regularly and enough that the family member could then come in and have that data on their phone for us to be able to utilise. They have a $20 trial offer when they purchased online. The Cybionics is actually been sponsored in Australia by, and I will pronounce it incorrectly, but it's by a company called Air Liquid. So Air Liquid has been in the obstructive sleep apnea space for about 20 plus years, and they have really recognised the emerging link between sleep apnea and diabetes. So while it's available online, I do believe going forward that it should also be available in some of their offices or their consult rooms for their sleep apnea clinics, which they do have rooms in Orange, Bathurst, and in Dubbo as well. That's its cost is $99 after that $20 trial offer. Okay, and then lastly, the AccuCheck Smart Guide. So we're all very familiar with the AccuCheck blood sugar monitors. But the Smart Guide, out of the three of the new players, the Smart Guide has the strongest focus on the Type 1 market. It is still approved in the Type 2 market, but some of their features are certainly more lent towards that Type 1 market. So there is essentially an app within an app. They call it a Predict, and it uses AI technology to help predict a hypo 2 hours ahead of time. So they use the analogy of it being like a weather map or weather app where that might predict that we're going to get rainfall. There is still, I suppose we just have to be a bit mindful of that. We know that weather apps don't always predict the rain effectively as well. But we just need to I would be talking to our clients about that. For some of our type 2 clients, I think that would confuse the fact as well. So we probably just be aware of clientele that you might talk to that about. It's a 14-day wear. And they do have a patient experience program, but it has to be done online, and they can get 2 free CGMs if purchased online through there. Cost ongoing is $99.95 for that. So that's a very quick summary of that. I know that I've probably gone shorter than time, but just to finish up, I'm just going to talk a little bit because I suppose all these new CGMs bring us to that bigger conversation about availability and affordability for clients living with type 2 diabetes, particularly if they're also using insulin. So this is just a little reminder for us out there to be talking to clients if they're interested to help with this, or also from a health professional point of view. MSAC has had a submission to them in the last little while, so the last, I think, 12 to 18 months, about getting CGM subsidised for certain populations within the type 2 space, as well as GDM or type 3C. Um, they didn't knock it back, but they did ask for more information. So they've deferred their decision. So this resubmission actually closes on the 14th of June. There's two different submissions available. I have got the websites on the screen there. So I did try to get a QR code and that just didn't seem to work. So there is one for the Dexcom One Plus and there is one for the Freestyle Libre. It's really asking just the practical questions. How beneficial has it been for you as a clinician or as a client? How has it helped you with your diabetes? And why is it so important that this technology is available at a subsidised rate if it could be? So the more that people can actually get on there and tell us what's happening, the more chance that we might be able to get the CGM subsidised for at least some other subsets of people living with diabetes moving forward. So yeah, that's my little talk. I'll stop sharing so I can see everyone else if that's okay for people, but feel free to ask some questions or clarify if you need to.
Thanks, Amanda. I'll just note that Manix also popped in the chat another sensor in case you
Oh,
needed
perfect.
OTI CGM
Okay.
is also on the market. My question is, with all these different CGMs available and all these different logins and all these different ways of presenting the data, is there any work being done that you're aware of on a sort of a unified kind of portal or app or something that clinicians can access so we're not having to have, five, six, seven different logins for each different patient?
Yeah, totally. My understanding, I haven't come across anything yet, and I would find that probably unlikely given that there's a number of different companies involved for that to be happening. But that's not to say it's not. Um, Certainly be things that we'll be following up with
Wouldn't that be nice
conversations.
if that was a condition of MSAC approving
Yeah,
of type
that'd
2
be
diabetes, is that they need to have an open API that's compatible?
that would be amazing. But yeah, as far as I know, not at this time. Keep my ears open for that one.
And any other questions? We've got a couple more minutes available for questions from the floor. Al, you look like you've unmuted.
Yeah, I can't find where the thing to put your hand up is. It throws me every time on Zoom. I was just going to comment more. I did have a client about 6 or 8 months ago that wanted to be using the OTI CGM because they were able to get it online from overseas a lot cheaper. And at the time, we reached out to the company to try and get some information. So I suppose whenever we're seeing a new product from our perspective, if we're recommending it to clients, we want to have an understanding of the safety of the client's information and the accuracy of the CGM device. And generally, people are quite responsive coming back to us, but that particular company didn't provide any valuable response to us. So at this stage, that's not one that we probably are encouraging clients to do. But Manik, if you know anything further on that, that would be great to be enlightened.
I'm going to basically echo what you said in that I contacted the company and asked, do you have reps that will give us some information as clinicians? And they said no, which is interesting because you're producing something for a diabetes market, but you're not wanting to engage with diabetes clinicians, which actually made me a bit apprehensive. So for me, it's a suboptimal option. But if it's an option that someone can afford over not having CGM, I've got so many patients who turn up to the appointments with no capillary measurements, then I will take the option of a $58 sensor that gets me some data versus them turning up with no data. But I'm certainly not recommending it, and I'm mentioning it to patients with the caveat that I have zero experience with it and I cannot vouch for its accuracy or safety. But $58 is much better than the other options.
And I'm
Yeah.
assuming, I'm assuming it's registered with TGA as a
I
clinical
think
lead.
so.
Yeah.
I
So I
do
guess that
think
was
so, but
specific.
they're not supplying any information. So these other three that I have talked about, and thanks Elle for raising that, we have ensured that data that they're keeping is all kept in Australia. It is satisfying all the global, so the European standards and the American standards in terms of data security and privacy aspects. So we're quite comfortable that people's data is safe, which that's one thing that we needed to consider. So with the Care Sense, I did say if they brought 6 at a time, it's $45. For one sensor, it's $55. So that could be another option for your Manic as well to pass that one on. And the rep has been really, so it's a New Zealand company, and the rep has been really really handy and responsive if you need anything.
That's great. Yeah, I'll reach out.
Thanks so much. I think that's all the time we've got for the didactic tonight. Thanks, Amanda. A really interesting space. Something unfortunately we're all going to have to keep on top of as it develops. So we'll pass on to our case study tonight by Erin, dietitian and CDE with Marathon Health. And her question is that this client's motivation to achieve her goal of pregnancy is so strong, and they are well versed in lifestyle strategies. However, there is generally some sort of barrier or excuse for not turning this into action. What else can I do to help facilitate action of good food choices and regular exercise? Take it away, Erin.
Thanks, Alex. Thanks, Amanda, for your presentation on the CGM. I think that was really useful and really timely, and I think a lot of us took more than a few snippets of information out of that. Erin, thank you for your case. Very challenging, very interesting, and I think a great learning opportunity, potentially with earlier onset type 2 diabetes, and also the widespread use of GLP-1s. Probably some of the discussion that we covered is going to be increasingly relevant across a broader range of clients moving forward. So you presented to us a 35-year-old lady with type 2 diabetes, and she'd had that for about 10 years with a strong desire for to fall pregnant, unable to tolerate metformin, but taking Ryzodeg. I've written Zyzodeg. Ryzodeg, 80 units twice a day, Ozempic currently. You've had the conversations around the risks, and she's well aware of the risks that come with conceiving while on medication that is currently not recommended during conception. However, there's a real fear that she potentially is not using contraception at the time, hoping to fall pregnant at any time. She's got some challenges. She's got an interesting past medical history with some, I guess, some complications to her well-being with the ulcerative colitis, GORD, asthma. And her father was diagnosed with type 2 diabetes in his 40s. It's interesting that she's got back and nerve ulnar pain, nerve pain that's impacting on her ability to work. And Alex sort of raised the point of what are her motivations for falling pregnant. She's got a lot of current challenges, and potentially the pregnancy will exacerbate some of those further, including her financial and social challenges. And if she's got the pain that's limiting her ability to work, it will likely impact on her parenting abilities as well. So her weight's 126 kilos, has been stable there, BMI of 46. Cholesterol potentially needs reviewing, and does need reviewing, and her blood pressure was okay. She seems to have good knowledge around pregnancy targets and the risks that come with elevated VGLs and taking the medications. But there's and so she's got good understanding of a lot of recommendations around her management, and tends to talk the talk, but something's blocking her from being able to implement changes and go along the journey of behavioural change to achieve her goal, which is to fall pregnant with minimal risk to herself and the baby. So I guess it was raised that it's really worth trying to unpack what those barriers to the behavioural change are, and it was mentioned that there could be some underlying mental health issues contributing to that, such as some sort of undiagnosed potential ADHD or past trauma or something contributing, some sort of personality factors contributing to blocking her motivation. It was also just noted that the 2 to 3 years that she's been trying is well beyond the recommended 6 months that is recommended in the guidelines for an assistive referral for fertility treatment. I thought it was interesting and really relevant, the comment that was made around being mindful of thinking forward. She's very focused on falling pregnant and what that would mean, but then looking beyond that, even for the health challenges she has at the moment, what do they look like post-pregnancy and how does she continue to manage those? And also the point that was raised about, if we're achieving glycemic targets through medication, when we're then changing those medications during pregnancy, there's a real risk that the glycemic levels are harder to manage as she hasn't implemented behavioural change to sort of stabilise those sugars, which would be of benefit if she was maintaining a pregnancy. Manik mentioned that there might be value in engaging with the partner and the family, potentially without her being involved in the conversation, just to really understand and unpack what's going on and what those barriers are to her engaging in treatment. She really does have a small window in terms of time if she was to achieve her goal. And Alex mentioned that, surgical intervention is probably one of the things that would achieve a result in a timely manner that she's looking for. However, it comes with its own myriad of challenges, and there's a real cost barrier that's likely to be relevant. The final recommendation that I've got written down was just to consider maybe going back to a basal bolus insulin regime so that you can more carefully manage her sugar levels, and again would require monitoring, so some sort of CGM or some structured monitoring from herself. And yes, someone in the audience or panelists did make mention to that, at some point it might just be a matter of having that conversation with someone and calling it as it is with tact, so that it's really seeing it for what it is and having a real conversation around what that means for her and what that will mean moving forward.
Thanks. What a wrap. And as you can see on our screens, that's the link for the evaluation. Please fill it out. It really helps us to deliver the content that helps you best. A reminder, of course, we've got our Diabetes Education Day on Saturday, the 13th of June in Dubbo at the zoo. Please register, sign up. It's great fun. Get to see each other face to face. We'll have an Echo Live session. Be great fun to have you all there, contributing, asking questions, giving your input as always. It's so valuable. And I think that's all we've got for tonight. If I could just ask the panelists to just stay on for a brief moment afterwards, just for a bit of planning. Otherwise, I wish you all a good night and thanks so much for joining us.